Now let's review the functional anatomy of the brain and compare VAN versus other large artery screening tools, right? Because now I've kind of gave you the basics of what the difference between large artery and small vessel stroke is. So now we know, right, motor weakness is used in almost all of the large vessel screening tools due to its central location, as well as its link to functional independence on the modified Rankin scale. This modified Rankin scale was used for all 5 endovascular stroke trials. So technically, having this type of weakness can predict, in a sense, if taking the clot out and giving you the ability to move again will make a difference in your functional outcome, right? So let's take a look. The first one is RACE, Rapid Assessment of Occlusion of Emergent Large Vessel Artery, right? And so this RACE score tests all of these: face, arm, leg, neglect, and inability to understand or talk, basically aphasia, and vision and gaze preference. But it's a relatively long exam. Look at this. You test face, you have to score 0, 1, or 2. You test arm, then you score 0, 1, or 2. You test leg, then you score 0, 1, or 2. You look at their head and their gaze deviation. You test aphasia. You have them asked to do both tests correctly, perform one test, 1 or 2. And then you have to tell, okay, is it the right side is weak or is it the left side is weak? You see how this scoring system, someone can probably say 1, someone can say 2, in all of these. And so the inter-observer reliability of this has to be questioned. In addition to this, now I went over pure lacunar syndromes, right? So you can have here, it says above 5, right? You can have a 1 here, 2, 2. It's a 5. This would tell you it's a large artery stroke, but guess what? 30–40% of the time it's not. It's a lacunar stroke. Only face, arm, and leg, right? So these are some of the things that we have to be concerned about. Legs, it's a similar one, but they don't test face or arm, and they neglect. Same thing, 0, 1, 2, 3, 4, 0, 1, 2, 3, 4, right? And they only test the leg, which to me doesn't make sense. It's the furthest things out, right? You can miss lots of small NIH, but large vessel occlusions, which can go on in the next 24 hours to become larger. So the use of leg only without the face and arm, it's so distal, you know, not always the best, but again, you have to calculate numbers, right? Right? And and again, it has a pretty good ability, you know, its sensitivity 69%, positive predictive value about 60, which is better than the positive predictive value of RACE, which was only 42%. All right. So the LA motor scale, well, neglects all cortical symptoms. It's just a motor scale, right? We talked about why this is not very smart due to all the lacunar strokes that present with pure motor symptoms. Again, and even this simple scale has you actually count all the numbers up. Oh yeah, if it's greater than that, then it has an 89% sensitivity and 89% specificity for large artery clot. But you have to score a lot, and on top of this, they don't tell you what the positive predictive value is. Hemiparesis, same problems. Cincinnati Pre-Hospital Stroke Severity Scale, similar. They neglect, and don't test vision, you know. But same with the other ones. Scoring as well. And only 40% specific. 3 items stroke scale, similar. Neglects lots of the aphasia, the neglect, the vision. Again, still makes you calculate scores. So VAN. So VAN tests all this, but you never have to calculate a score. And guess what? Just like all the pure motor ones, we put motor in the middle. It's the first thing we do. We have you put up the arm for 10 seconds. If you have 0 weakness, you're done. You're done with the exam within 15 seconds. You don't have to do the entire exam like all of these and calculate numbers, right? But then we don't neglect anything. We don't neglect any cortical symptoms, right? So let's compare RACE, legs, LAM, CPSS, and VAN, right? Test cortical symptoms, yes we do. These other ones do as well, right? This is a pure motor one, so it doesn't. No need to calculate score, that's us. Everyone else has to. No need to test severity, that's only us. Everyone else has to. Does not test one MCA branch multiple times. They all do, because they test face and arm, or face, arm, and leg, right? Right? Has online forms. We do. You can download our forms. Has website and teaching videos. None for the others. So why VAN? We just went over this. No calculation of numerical score. Uses motor weakness as central point to triage. Uses cortical symptoms without severity and scoring, which actually allows for better inter-observer reliability. VAN teaches what cortical symptoms are. I just taught you over this last lecture. The mnemonic helps. VAN, oh yeah, vision, aphasia, neglect. Dr. Taleb went over this, right? And does not overtest one division of the MCA by testing face and arm and leg, or face, arm, leg, and hand, right? So for us, we've had 6 patients with NIHO scales of greater than 10, all turned out to be lacunar, all VAN negative, because they were pure motor and sensory with no cortical symptoms. And so that's why it's powerful. It's in a sense the simplest and the best, all in one.